Yo soy curioso, ¿qué es el porcentaje de cesárea en Colombia? En el hospital privada. 60%. El 30% overall? Okay. Estados Unidos es 31% overall. A Cornell es 40%. But now we're talking about a completely different animal because we're talking about twins. Twins. Is there still a role for vaginal delivery of twins? Very controversial. I expect a lot of questions, and I welcome your contradiction and your disagreements. Twin pregnancy, as you know, the frequency has increased by 65% in the U.S., 3% in Canada. In the US. In Canada, it went from 1.8 to 3%. In the Netherlands, similar trend. It contributes to a considerable morbidity and mortality, obviously, because twins are at so much higher risk of preterm birth, low birth weight, and in fact, even if they constitute a small percentage of the total obstetrical population, they contribute to 10% of the perinatal mortality. And overall, the perinatal mortality rate is 7 times over a singleton. I was shocked recently to find out that the rate of single embryo transfer for IVF, because IVF has become so much more common in the States, is 2.7% in the States. While in most Western countries, European countries, it's much, much higher, and they have much more stringent regulation. I don't know what it is in South America, and I'll welcome your input on that one. But certainly it has increased the rate of twins significantly. I'm not going to talk very much about the antepartum events because we know that twins are at risk of twin-to-twin transfusion syndrome, anomalies, IUGR, IUFD, preterm labor, preterm delivery. I'm going to talk about mode of delivery and the presentation. It's still controversial, especially for vertex twins. The multiple retrospective studies and only one small randomized controlled trial which dated from a long time ago. And there's one ongoing randomized controlled trial looking at vaginal delivery of twins, randomized to C-section or vaginal delivery, vertex twins included. So the problem in the studies of twins that, as I said, is mostly retrospective and not always clear. They mishmash together vertex, breach, vertex, breach in their outcomes. And there's morbidity and morbidity, because if we talk about a little cut on the buttocks when you C-section versus a serious neck injury of a difficult breech extraction, these are totally different. And sometimes when you look at composite outcomes, they put all of them together. So what is the pros of doing routine C-section of all twins? I think Dr. Grunebaum will agree with that, is that you get overall C-sections, I'm certain the same in Colombia, you get overall low morbidity, especially when it's elective. Now we have a trend towards a decreased parity. These para 17 anymore don't exist anymore very much. We have a few clusters in New York that do have 17 kids, but they're quite rare. A C-section is predictable, unlike labor, which is very often unpredictable. You get often malpresentation of twins, at least in 50% of the time. One of the twins is malpresented. Therefore, not forcing, but prompting the obstetrician to do a C-section. There's less and less experience with vaginal breech delivery. There's no doubt about it. I remember last year a patient arrived in our labor and delivery ward into a second baby, And fortunately, she was French, and I'm French speaking, and I had never seen her in my life ever. She was not my patient. And the doctor called me, says, like, I've got a multip on the way with twins, vertex breach, her plan is for vaginal delivery. Are you comfortable with that? Being trained in Canada, where I've done tons of breech deliveries, I said, yes, I am. And the first thing she said was she walked in. First mistake that was made, and I think it also pertains a little bit to Dr. Grunbaum's talk, is safety in labor and delivery ward. When a patient comes to you in the labor and delivery area like this and huffing and puffing and like, I want to push, this is not a patient you put in a triage unit. This patient was pushed in the triage unit and delivered vertex, the first one, in triage, which was not optimal. And then the second twin was indeed breech. And I said, well, now we have time. Membranes are intact. Let's transfer her to the operating room where she can have a safe, hopefully safe vaginal breech delivery. We had a very 5-minute short talk in her language. And she said she was accepting all the complications potentially of a breech delivery of a twin. Because twin deliveries, breech deliveries are so rare, there was about 22 people in the delivery room. It was very interesting. As a result, she pushed twice, and the baby came out with APGARs of 12 and 12. I'm serious. It was really, really, really easy. So unfortunately, because residents are not exposed to breech delivery, less and less are willing to tempt that. The pros of doing a C-section also for twins is that there'll be at least a 6 to 10% need for combined vaginal breech C-section combo. I call it the obstetrical combo platter, and this is my least favorite thing. You get a total obstetrical experience of pushing 2 hours for a first twin or 1 hour and ending up with a C-section for the second twin. Terrible. We hate it. And also, one of the reasons for elective C-section of breech is that it's difficult sometimes to monitor twin B. However, the cons is that a C-section is still an abdominal surgery. The most presentation is vertex-vertex. The cervix is, I've never seen a patient at term actually with an unfavorable cervix with twins. It's very unusual. They're almost always favorable. The presenting part is very, very low. Labor is very short because twins are usually smaller. And the problem if you plan a C-section at 38 weeks, which is our guidelines in the States, very often they go into labor before you plan C-section. So transforming a planned C-section into an unplanned C-section, which increases the morbidity of the operation. And most patients deliver vaginally, uneventfully. So that's one of the cons of doing C-section routinely in all the twins. So I'm going to look at some things here. Is there increased perinatal mortality in twin B? Is there increased intrapartum mortality in twin B? Is there increased intrapartum morbidity in twin B? And if the answer is yes, can it be prevented by doing a C-section up front for all the twins? And can these findings be generalized to term and preterm twins and fetus of all birth weights? Let's talk about IUFD of twin B. There was a study done in the US recently, fairly recently, looking at all the statistics of birth records in the States involving over nearly 300,000 twin pairs. And this showed that clearly twin B had a higher rate of perinatal mortality, clearly a higher rate of stillbirth. In terms of neonatal mortality, there was no difference. So no obvious intrapartum mortality and neonatal mortality, but there was no control, unfortunately, in the mode of delivery, in the hypoxia complication and chorionicity, which we know is very important because we know that the mono-di twins will have a completely different set of complications as the di-di twins. And the IUFD fetuses tend to deliver twin B. If you have a baby that died at 27 weeks and a remaining twin, usually twin B will deliver second, which could significantly bias the rate of stillbirth in that study. So is there an intrapartum mortality and morbidity in twin B? That has been studied extensively by a group from Canada, but looking mainly at data from the States, looking at vertex, non-vertex second twins, vertex, and all this stuff. They looked at all the births that took place between 95 and 97. It was a retrospective cohort. They looked at data from the CDC of over 150,000 twin pair. And it was pretty neat because this time they really did logistic regression, looking for confounding variables, control for anomalies, age, race, marital status, pregnancy complication, and fetal distress. And they studied in twin B versus twin A in terms of neonatal morbidity and mortality, low 5-minute APGARs, need for mechanical ventilation, respiratory distress syndrome, and seizures. So real complications, not this little cut on the butt when you do a C-section. And they looked at mode of delivery if there were a C-section for both twins, which was the reference group, vaginal, and the combo vaginal cesarean, the presentation of twin B, the birth weight of gestational age. In terms of, let's look at the first study, the mode of delivery of the non-vertex twin B, okay? And look at the asphyxia-related death in the non-vertex twin B. If you look at the small birth weight, if you had C-section done for both, as a reference group, you have an odds ratio of 1, obviously. If you had a vaginal delivery of both, you had significantly more risk of asphyxia-related complication, which is an odds ratio of 7.6. And if you had a combination of vaginal C-section, also significantly increased risk of asphyxia-related death. But that difference could have been due to the low numbers in the combo vaginal C-section, but still significant differences. So, in conclusion, I didn't have enough numbers to show differences in the birth weight more than 1.5 kilo. And there was definitely an increased neonatal death with trial of labor in the small twin B non-vertex. That was the conclusion of that study. For twins more than 1 kilo, let's look at birth trauma now. There was, if you use a C-section as your reference group, if you had a vaginal delivery of both twins, there was a 50-time odds ratio of 50 of birth trauma for vaginal delivery for twin B, and a combo of vaginal C-section, an odds ratio of 14. Much more seizures also in the vaginal delivery of twin B in both vaginal and vaginal C-section combo. So increased birth trauma and seizures when the second twin B was non-vertex. So no wonder cephalics, non-cephalic twins are mostly born by C-section in the United States. I don't know about here. I'd be curious to know. When you had a combined delivery, similar story. Also much more, if you look at death, asphyxia-related death, much more complications in term and both preterm babies. Armstrong looked at data in Canada now between 1988 and 2002, looking at 1,500 twin pairs. 20% of C-sections were done before the onset of labor. And they noted that when you compare twin A to twin B at term, they had composite outcome, but only for serious neonatal morbidity of the second twin, such as perinatal death, seizure, intubation, infection, and birth trauma. And it was very clear that in twin B, they had an incidence of 33 per 1,000 incidence of these serious outcome compared to twin A of 13 per 1,000. Similar picture when you have a birth between 34 and 37 weeks and less than 34 weeks. Less than 34 weeks, I'm not saying it's you're probably going to have less trauma, but you can have such a higher incidence of seizure anyway in twin A that the differences probably are a bit smaller. I showed you this data already. If you look at the planned C-section, if you have a planned C-section at 37 weeks, the incidence was the same, 11 per 1,000 risk of perinatal death. And if you had a planned vaginal birth, much higher incidence of composite bad outcomes. So overall, for twin B, you have a higher incidence of neonatal death due to trial of labor. For the small non-vertex twin B, we can conclude from these studies, increased birth trauma and seizures in the trial of labor for the non-vertex twin B, increased asphyxia-related death, especially in preterm of all presentation, increased composite morbidity with trial of labor of all presentation, and increased composite morbidity with the trial of labor, even in vertex twins. So is there an increased mortality and morbidity in twin B when they're born vaginally? Probably. Can it be prevented with a C-section? Maybe. There's a study looking at that presently in Canada, as I said, the twin birth study. It's almost over. Where they randomized patients to vaginal versus C-section. The data should be available within a few years, or even less than that. And let's talk about our worst-case scenario of the combined vaginal birth of twin A and a C-section of twin B. The most common reason for doing a C-section of twin B is cord prolapse, a sudden abnormal fetal heart rate for placental detachment, significantly larger size, and I'll say an indication I didn't add, but personally my experience, also sometimes what you think is vertex, well, it becomes vertex something else. All of a sudden the twin A delivers and twin B flips, and then you have more complications. Many studies on that show that you have an adjusted odds ratio of 4 in terms of perinatal death when you have a combination of vaginal C-section for twin A and twin B. Same thing here for the incidence of seizures. Seizures, if you adjusted odds ratio of 4.12, if twin B was delivered by C-section after vaginal delivery of twin A. Same thing for low Apgars. Okay, so twin A non-vertex, twin A B non-vertex, and vertex. Twin A non-vertex, I think it's almost not worth talking about it because there's so few people that will deliver a pair of twins when the first twin is presenting non-cephalic. But nevertheless, there's some data showing that you have significantly increased mortality in vaginally delivered breaches, especially when the breaches are small, and you have this rare but sometimes happens incidence of interlocking twins when the first one is breech and twin B is cephalic. And a small word about the twin breech trial. The term breech trial, which was conducted in Canada, an international study, I think clearly showed that it's safer to deliver a singleton breech by C-section. It decreases the incidence of mortality and morbidity in the singleton breech. Can we generalize that to twins? Probably not, but nevertheless, what it caused is a decreased incidence of experience in breech deliveries in many of our new graduates. So in vertex, non-vertex, you can do a C-section. There's absolutely nothing wrong with that. But if you still want to do vaginal delivery, you can deliver twin A vaginally, obviously. Following twin vaginal cephalic delivery of twin A, you have the twin B, you can deliver as a breech or do an axialocephalic version or an emergency C-section, which is probably the last thing you want to do. My favorite thing for this rare patient that wants a breech delivery would be to let the breech come on its own until I see the scapula. I tell the residents, put your hands behind your back. Don't do anything until you see the scapula. Then you deliver this second twin B, not by extraction, but by spontaneous pushing of the mother and spontaneous contraction of the uterus. Vertex, more controversial, based on many retrospective cohort, but most studies suggest an increase, again, morbidity and mortality for the second twin, even for vertex. And decreased morbidity of twin B when vaginal delivery is not attempted. However, to date, there's no randomized controlled trial, and there's one on the way. And I think at Cornell, even overall, the twins are born 70 to 80% via C-section. Even vertex, most patients will choose C-section because many of our patients are in the late 30s, 40s, or even more than that, as I'll talk later. And they don't plan to have 18 more children, so the morbidity associated with C-section is not as high as it used to be. So even for vertex is quite acceptable for us, and the majority of our patients will choose to deliver via C-section. Conclusion, is there still a role for vaginal delivery of twins? The answer, it depends. It depends on the local availability and the safety of the C-section, of the experience of the operator. My bias, the last thing you want to do if you want to attempt a vaginal delivery of twins of all presentations, if you have a prior C-section, there's nothing worse than doing a stat C-section for a twin B and a patient who had a prior C-section. So if you had a prior C-section and the patient is insisting on a VBAC of her twins, try to convince her not to do it because I don't think it's a very good idea. Thank you very much. I'll be welcome to answer any questions.
Bueno, yo creo que ahora le toca la charla al doctor.